Good evening, good afternoon, good morning, wherever you are. My name is Hakan Ömeroğlu. I am the president of the European Pediatric Orthopedic Society, and I welcome you to the European Pediatric Orthopedic Society and Pediatric Orthopedic Society of India combined webinar entitled Common Complications and Their Management in Pediatric Orthopedics. And I would like first to thank Sebastian Farr and Viraj Shingade for making this great program, and also Elke Viveger and Rijuta Mehta for their contribution to this great program. And I also like to thank all the faculty members for kindly sharing their great experience with us. And EPOS is willing to continue the collaboration between the sister societies by educational and scientific means, and we look forward to improve such collaborations with our sister societies. And I would again like to thank you for kindly attending this webinar, and I'm giving the microphone to Dr. Ara Jois. Thank you.
Thank you, Hakan. I'm Alaric Arujas. I'm the president of the Pediatric Orthopedic Society of India. And along with Hakan, I'd like to welcome all of you delegates and faculty from wherever you're joining from around the world. It's really amazing to have this first collaborative webinar between EPOS and POSI. It is something we've been trying to do for many years now. And I must really thank my friend Ignacio Sampera, the past president of EPOS, and Hakan Ömeroğlu, the current president, for encouraging this collaboration. The seeds for this were set, in fact, by many of our seniors. Dr. Johari, who's the founder president of the Pediatric Orthopedic Society of India, who's now the faculty for this conference. Dr. Benjamin Joseph, who began some initial collaboration with EPOS. And the roots for this webinar actually was the immediate past president, Dhiren Ganjwala, who took the step forward to collaborate with Sebastian to develop this entire webinar. I'm really excited by the fact that our two great sister societies are getting together, and I'm sure this will be the start of many more such collaborations, not just in terms of webinars, but also in terms of fellowships and some other collaborations as well that we have been talking about. We all know that, unfortunately, India has the privilege, I would say, of being the largest and the most populous country in the world with 1.5 billion population. Europe having just half of that at 750 million. And yet, both our societies have approximately the same number of members, about 750 pediatric orthopedists from around the world. And that's really interesting. We are the second largest pediatric orthopedic society in the English-speaking world after POSI. So really, we have a lot of heft in the global outlook, and I'm sure that this collaboration will go a long way forward in cementing closer ties between EPOS and POSI. So I wish all of you a very wonderful webinar and all the best to our speakers. Thank you very much.
Yes, so from me, my name is Sebastian Farr from Vienna, Austria. I serve as the EPOS Educational Committee Chair. I would also like to warmly welcome you to this first combined webinar. It is my utmost pleasure to introduce my co-moderator, Elke Viehweger from Basel, Switzerland, and our renowned EPOS speakers. We have Dr. Nicolas Lutz from Lausanne, Switzerland, who will speak about the compartment syndrome and how to intervene. We have Professor Björn Vogt from Münster, Germany, who will speak about common complications of limb lengthening. And we have Professor Frank Ackertblad from Toulouse, France, who will speak about common complications in arthroscopic surgery. And now I would like to give the voice to my co-chair, Dr. Shingade, who will introduce the POSI speakers to you.
Hi, good evening to everyone. Thanks to Dr. Farr as well as Dr. Hakan for having this wonderful collaboration. And we have today with us Dr. Rijuta Mehta, who is going to be the co-moderator. She is a consultant as well as head of department at Paediatric Children's Hospital, Mumbai. We have excellent speakers from POSI side. Professor Dr. Ashok Zohri, who is going to talk about the management of late presenting DDH after walking age. Professor Ashok Zohri doesn't need introduction. He is founder president of POSI and mentor for almost all the practicing pediatric orthopedic surgeons in India. And he's also editor of JPOB, and he has excellent his experience of last 40 years in this field in India. I think he has the largest experience no one has in India like him. Then another speaker is Dr. Jayant Sampath. He is a practicing pediatric orthopedic surgeon in Bangalore. He has tremendous work in cerebral palsy, and he has his own gait lab, one of the first gait lab to have in India. So Dr. Jayant Sampath. So he is going to speak on recurrent spastic hip dislocation. And then we have another speaker, Dr. John Mukhopadhyay. He's a senior pediatric orthopedic surgeon as well as a trauma surgeon working in the northeast part of the India, Patna. He's working and he's the author of many books, as well as he has faculty for many international conferences, and he has excellent and tremendous experience of the neglected trauma. And Dr. John Mukhopadhyay will be speaking on the malunited forearm fractures. So thank you once again for all of you and all the attendees for this program. I welcome and hand over mic to the next speaker.
So please, Dr. Lutz, can you start with the first presentation?
Yes, sir. Good morning, everybody. Good afternoon, everybody. I hope you can see. Let's confirm that you can see. I would appreciate if somebody could confirm.
Not yet. Let me just do something, just 1 second, and then let's see if you can do it now. I will give you, okay, now it should be better. Please confirm.
Yes.
Thank you.
Thank you very much. It's a pleasure for me to be among such an amazing and impressive team from small Switzerland, even in Europe. I was asked to speak to you about something that is not very common and always a challenge, especially not when you have to perform it, but how to recognize it. Compartment syndrome in children is basically something where once performed, you have to think about how to close it, and I will share some of the experience with it. I would like to share some thoughts about the pressures and the measurements, as well as discussing this eventually, which is basically a clinical diagnosis, although we talk a lot about pressures, and share some of the thoughts about the different parts of the body, but where it can happen. Basically, in the leg, if you want to have to perform a fasciotomy, there are 4 compartments, and you can either do a 2-incision or 1-incision procedure. I have a colleague in Paris, Laurent Mathieu. He's an army surgeon, and he likes to do a large lateral incision, extended all over the lateral part of the leg. He has no tibia exposure, but he can this way enter completely all 4 compartments by going, once he has done his general lateral incision along the fibula, entering the lateral compartment first and then going anterior, and then by going under the fibula, going into the deep posterior and posterior compartment syndrome, into the compartments. I like to do it with 2 incisions, 1 lateral posterior medial and 1 anterolateral. That may allow maybe a less significant incision on the leg and allows you to open all 4 compartments. With the posterior medial incision, you can enter both deep and posterior compartments, and with the anterolateral, you can enter the lateral and anterior compartment. This is how it looks like once you've opened, and then you have already to think about how to close it. And there are various ways of closing. You can use dermotraction, you can use gradual approximation. Some have used the back, and sometimes you may decide not to close completely and then to just close the skin with skin graft. This is a way of how we proceed with using tension band and gradual traction. Overall, here is one medial part of the leg. And then once the skin is approximated, you can then eventually close it with stitches. This is also sometimes necessary to use temporary skin closures before your issues are settled, and then use dermotraction and then close eventually the skin. Few studies have compared the different techniques, but basically if you are used to the VAC system, you will eventually have quite a good success, around 80%, but are encountering more complication than if you use dermotraction with a better success and less complications. Pressures are a common subject of discussions. Once you clinically suspect compartment syndromes, you have many tools that allow you to measure the compartments. You will have to measure each of them in the operating room to have proper measurements, and it is known that in the child the pressures are normally higher than in the adult in the lower lower extremity, but most of them, as you can see, will remain under 20 millimeters of mercury. The highest pressure will be around 5 centimeters of the fracture zone, and that is something you have to be aware of when you start measuring. A team in Zurich published 7 years ago a study where they measured the compartment pressures in both normal and fractured forearm of children who had to go through some surgery or some manipulation under anesthesia. And surprisingly, as you can see, some of the pressures in the fracture forearm were way above the 30 limit, even going close to 50 millimeters of mercury. None of these children encountered a problem of compartment syndrome, and none of these children had to have a fasciotomy. This other study also measured the pressures in the leg and found some high pressures, although none of them eventually had a compartment syndrome, and they observed that in 13 of these children the perfusion gradient was quite low, below the 30 millimeters of mercury, which you want to have some flow in the leg, but none of these children encountered a compartment syndrome. So pressures above 30 millimeters of mercury do not always equal to a compartment syndrome, and that is to be known in a child. You can also use the differential pressure, which is the pressure between the diastolic blood pressure and the intracompartmental pressure. It is suggested that if this pressure is below 30, it will be suggestive of a compartment syndrome, but that is again not always the case in children. So basically, whatever you measure, whatever you encounter, the compartment syndrome and the pressures, they all equal to your experience and basically is a clinical diagnosis. It can occur, and most often will occur, in the leg around the tibia, and it is not infrequent to find it with fractures who are secondary to high energy injuries or proximal tibia fractures affecting the blood vessels just below the popliteal. It will be less frequent in the forearm, and in the few studies that have looked at the reasons for compartment syndrome to occur in the forearm are basically related to a long manipulation, such as in this study from Philadelphia, where you can see that they fiddled around a forearm for more than 2 hours to eventually nail, and that can eventually is a leading thought for secondary compartment syndrome. And they also found that the nailing had to occur very quickly, basically probably for very displaced fractures, then the risk of a compartment syndrome is higher. It can occur in the with supracondylar fracture, and this is quite low. Basically, the red flags in this area are a significant swelling or poorly perfused hand, or when there is a vascular injury, or again, if you are conservative and then try and bend more than 90 degrees your elbow for immobilization, you may affect the blood supply to the distal part of your arm. It is even rarer, but possible for floating elbow fractures. It can happen in the foot or in the hand, and very rarely around the femur. Compartment syndrome is really a clinical diagnosis. It used to be said that the 5 Ps, which is pain, paresthesia, paralysis, pallor, and pulselessness, were the ones to use in children. We tend to speak about the 3 As, which are agitation. A child may not express the possibility of his expressing his pain. He's got anxiety, or you have to increase your use of analgesic to a very high demand. I would say the 4 A's, because we tend to close our eyes when we're concerned and wonder if this is really a compartment syndrome happening. Again, the timing to incision, as you can see in those studies, is always higher than when it is thought. It is around the 27, you see the 20 hours. This is much longer than what is suggested, because the compartment syndrome is a clinical diagnosis and it has to be recognized early, and you have to develop awareness about it. The fasciotomy should be performed within 8 hours, and that would be the optimal, because nerve injuries can happen. They start 30 minutes after your pressures are very high, and they can be irreversible after 12 hours. The ischemia is again something in the muscle that will happen very quickly and can be irreversible early as 4 hours following trauma. In summary, compartment syndrome in children is it's a clinical diagnosis, and it is a true pediatric emergency. Thank you.
So is that visible?
Yes.
Yeah.
You just need to put your presentation on. Thank you.
Yeah, I put it on. Is that not on?
Not yet. We can see your screen, but not the presentation itself.
Let me do it again.
Can you share your screen, John?
Yeah, I thought I did that. Stop sharing. Show screen is there.
You are showing your screen, Dr. Mukhopadhyay, but you would need to put on the screen your presentation, please.
Yeah, I've done that. Is that there now?
No, you would. We can see only the URL access at the moment. So if you put your presentation as a full screen.
Screen is paused. Should I go stop and start again?
No, I don't think that's the problem. It was more that the presentation.
It says paused.
Okay, let me do a little thing here, a quick thing, and I give you again the right to share. Just 1 second. Now it's very good. Now you have, Dr. Mukhopadhyay, you have paused your video. Would you mind putting your video back on? We can see your presentation now. Excellent. Now you can go. Dr. Mukhopadhyay, you are muted at the moment, unfortunately.
So, is that okay now?
Yes, everything is perfect. Please go ahead.
Thanks.
Thank you.
Okay, sorry about this. It's a real pleasure to be part of this program today. And I'm going to talk about the malunited forearm fractures, whether we can allow them to remodel or we need to intervene surgically. To start with, there's no conflict of interest with respect to this presentation. Remember, the forearm consists of two bones with an interosseous membrane in between. And in children, many of these can be treated conservatively, unlike that in the adults. However, redisplacement after close manipulation with conservative treatment is not uncommon, and angulation, if significant, can affect the rotation. There is a remodeling potential which varies with the age. Obviously, with the younger child, there's more potential for remodeling, and it is more towards the distal end than the proximal because that is the growing end of the forearm bones. Now we'll start with a not so uncommon presentation. We have a 12-year-old boy with fracture both bones of his forearm who has been treated at another clinic with close reduction and above elbow cast. And he presents to you at 2 months post-injury when the cast has just been removed and the x-rays that has been done. These are the initial x-rays with the post-reduction films on the right. And then this is at 2 months when he presents to you, the cast has been removed. And obviously, there's parental anxiety as to whether something needs to be done. And you need to really look at this carefully to decide whether something needs to be done. Now, if you look at the literature on what is acceptable, and this is the one from Price in 1990, they said that in the age above 9 years, only 10 degrees of angulation is acceptable. Now, in this case, if we looked at the angulation, the dorsovolar angulation, it's probably around 15 degrees. But there's also another issue in this literature which mentioned that there's no real clear correlation between the angulation and loss of rotation. So there's another study which is by Evans, which is way back in 1951, which looked at the radius and the ulna. The radius in the AP view, they looked at the radial styloid and the radial tuberosity, while in the lateral view, they looked at the coronoid process of the ulna and the ulnar styloid. And these tend to be at 180 degrees to each other if there is no malrotation. And so when we looked at this from this point of view, we found that there was a fairly good rotational alignment of the bone. So we decided to treat this conservatively. And at the end of 1 year, that was his clinical and radiological result. You can see that he's got a good, almost a full range of motion in terms of supination, pronation, as well as fairly good remodeling of his fracture. Now, there are various papers which have looked at what is acceptable. Of course, the Price's one in 1990 was the first one, but it was followed up by another one in 2010. And there are other papers which accept various degrees of malrotation and angulation in children. And this is another paper by Walter Trung et al. In the POSI journal, which looks at what is acceptable. And again, you can see a huge variety between the paper by Waters in 2010 and the paper by Crawford in 2012, that the amount of acceptance of angulation can vary a lot with different people. Here's another situation which is not uncommon, where you have what looks like a fairly innocuous distal radial shaft fracture. This has been treated by a nail elsewhere. And it's interesting that the nail was removed at about 5 weeks, and gradually you can see how this has angulated, and the distal radial ulnar joint has subluxated. And he presents to us almost at 6 months down the line with this kind of severe angulation and subluxation of the distal radial ulnar joint. And here, I think we went in, we did a osteotomy to correct the radial bow, and that actually brought the distal ulnar into the correct position as well. So we did not have to do any ulnar shortening. So it's interesting that this is him at 2.5 years post surgery. You can see he's got back a full range of rotation and a good functional position as well as cosmesis. So interestingly, there's literature support for this as of correcting the radial angulation for these patients who have distal radioulnar joint problems as well, following a distal radius fracture, with fairly good results in their study. This is an interesting case. This is a 4-year-old child who was treated conservatively elsewhere, and she came to us 4 months down the line with this position. Now you can see that she's got quite a significant loss of supination. So I actually put this on our POSI group, and most people suggested I should correct the radius. The plan was to go with a nail, obviously, in this age, but it was interesting that when we tried to pass the titanium elastic nail, it just wouldn't go in the correct direction and would go out of the bone. So we ended up putting a mini plate, a 2.7 millimeter plate from the distal radius set, and this then went on to heal well, as you can see, with good correction of rotation as well as good function at the end of it. And this is at 1.5 years when we removed the implants. You can see she's got back almost a full range of rotation and a perfectly normal looking forearm. Of course, in adolescents, the situation is different. You would treat them almost like young adults. And so if you have a malunion such as this presenting, this was at about 4 months post-injury, I think there's not much doubt about where you would do, what you would do. You go in, you do an open reduction, do an osteotomy, correct the deformity, and then fix it with compression plating, as we did in this case. And this goes on to heal well with, again, good function. So I think in adolescents, as the child gets older, we tend to treat them more and more like we would do in an adult. They've looked at the remodeling speed in the distal radius fractures, and it's interesting that the remodeling speed is the maximum in the first few months and changes exponentially over time. So they studied 33 children with more than 15 degrees of angulation, and they found that the angulation changed from 23 degrees to 8 degrees at the end of a year, and I think it was 15 months or so that they looked at, and all distal radius fractures showed remodeling. So this is also the distal radial physeal injury is one which remodels very well. This was interesting, a case which was treated by one of the other surgeons in our hospital, initially presented with this lateral condyle fracture. The wrist injury was not noticed at this stage, so the lateral condyle fracture was pinned, and when they came to take out the cast and the K-wire, they noticed a deformity at the wrist, which the parents also complained about, and the X-ray showed that there was a physeal injury which was missed altogether with a significant displacement. Now, however, 1 month down the line, this has a great remodeling potential, so they took my opinion and I said, leave it alone, it will remodel. And this is what happened. This is at about 2 months down the line, and at 4 months down the line, you can hardly make out that there was an injury in the distal radius. You also have to differentiate between presentation in the early stages of a malunion, which is sometimes referred to as a nascent malunion. This is at maybe 2.5, 3 weeks to about 4, 5 weeks down the line before the bone has fully united. And at this stage, you might be able to do an osteoclasis or percutaneous osteotomies to correct these deformities, and probably your threshold for going in and doing something would be a little less in this stage. So here's the study which looked at early correction of pediatric malunited distal metaphyseal radius fractures using a percutaneous callus osteoclasis technique with excellent results. The other risk factors which we look at in terms of malunions are the initial displacement, which was shown by Akun et al. That if there was more than 50% displacement and 20 degrees angulation, the risk of malunions were higher. The patients who come with gross swelling, of course, when you do closed reduction without fixation, the risk of displacement is higher. Failure to obtain anatomical reduction is another risk factor for developing a malunion, as shown by Nietsvara et al. In their study. And of course, the cast index is important when you're dealing with these fractures. The future may be in using 3D analysis and techniques, sort of remodel techniques to look at how you can do the osteotomies so that you get good results. And this is a study by Casper Roth et al. And a follow-up study at looking at factors determining outcomes of corrective osteotomy for malunited pediatric forearm fractures, which was a meta-analysis. And they looked at multiple studies, including some which used computer-guided correction. And they found that the factors which contributed to a better result included if there was a time of injury less than 1 year, the angulation was less than 20 degrees, and the use of 3D computer-assisted techniques increased the chances of getting a good result. So in conclusion, I'd just like to say that malunions and forearm fractures are not uncommon. I think there's a significant remodeling potential. However, this is not always predictable. The functional deficit varies. It definitely increases with the increasing angulation, but is not always directly correlated. And the acceptability varies in different studies. So I think you need to look at all the studies and decide on your own method of treatment or your own acceptance criteria. And you need to counsel the parents very clearly about this, because that is what eventually is important to have a satisfactory result. Thank you very much. I will stop there. And I go to stop sharing. I hope that works. Is that okay? Hello?
Yeah.
Yes, it's okay. Dr. Mukhopadhyay, you can remove your camera and mute yourself, please. Thank you.
Well, greetings everyone from Mumbai, everyone on this webinar. Well, I have to be heard, not seen, because my camera decided to malfunction. So please bear with me. I'm going to be speaking on management of late presenting DDH after walking age. Now, in an ideal world, the best time to detect DDH would be at birth, because we all know that early treatment is simpler and has better outcomes. However, this is an unequal world, and we have the developing world where you see this sort of presentation anywhere up to even the age of 40, undiagnosed or untreated developmental dysplasia of the hip joint. So why late? Why does it happen late? And we try to analyze this in a series of about 54 patients who presented late to us. Well, they became suspicious that there was something wrong when the child started walking, because the child would walk on the toes. It took another 5 months or so, for them to consult a doctor. This shows the prevailing conditions in different parts of the country here. From consultation to diagnosis, again 5 months, because they went to the peripheral hospitals. From peripheral hospitals, they were referred to the central institutes, etc. So it took a long time. And from diagnosis to treatment, well, it took nearly a year because of uncertainties, because of socioeconomic problems. Well, this chart shows you, delay in detection could be because of family and social factors or physician-related factors. And even in management, the same thing applies, whether it's poverty, ignorance, or the physician is not qualified to treat a case of DDH. So late presenting DDH is not uncommon in our part of the world, and there could be two varieties. One could be untreated or residue of a treated DDH, and the second could be adolescent acetabular dysplasia, which is diagnosed, of course, when it becomes symptomatic. Well, we base our treatment protocol on this particular article, which I written for a book, this chapter. Now I show you an example here. This is an 11-year-old child presenting with hip pain in the right hip, and you see that his gait is antalgic. Well, this is his clinical picture. Again, a year later, actually, when he came up seriously to have something done, well, this was at the age of 12. And then he finally had surgery at the age of 13 years, bilateral DDH, high-ridden DDH, untreated. And this was the surgical sort of exercise we did, and the X-ray pictures after that in 2016. Well, this is his post-surgery video and pictures showing the function. And this is his recent follow-up, maybe about 7 years or so after the surgery. Well, the situation is not ideal, but he has stable hips. His pain has disappeared, and he is walking fairly well. So when we talk of, I'm going to be focusing on surgery, surgery in late presenting DDH. We know that conservative management is an option in the younger late presenters, but generally in our sort of situation, we have these late presenters who are much beyond the age of 3. We resort to an open reduction. Well, one would check the stability after an open reduction, and if the head is stable in a neutral position, no femoral osteotomy is required. If the head is stable in abduction, then we do a varus osteotomy. In internal rotation, and of course there's a range more than 20 degrees of internal rotation, one would do a derotation osteotomy. Now, if there is a difficulty in reduction, we do a femoral shortening. If there is acetabular dysplasia, one would do a pelvic procedure. So open reduction with femoral osteotomy is done where abduction or internal rotation of more than 20 degrees is required for stability. Well, here's an example of an open reduction with a varus derotation osteotomy. In a 3-year-old, she had an open reduction and a varus osteotomy. And this is the picture after 10 years of the surgery. Functionally, she is very good. And again, longer follow-up. This is at the age of 20. So this is the sort of result we have of a femoral osteotomy. The acetabular dysplasia was present, but then that has now disappeared. So when do we do an acetabular procedure? Where there is a acetabular dysplasia present and the hip is stable in a neutral position after an open reduction. Well, surgery in late presenting DDH, we speak about pelvic procedures, and different pelvic procedures are known. In the skeletally immature child with a concentric reduction, one can do a Salter's procedure or its variant in an older child like the Tonys or the Steele osteotomy. Where concentric reduction is not possible and you have a large acetabulum, Dega or a Pemberton osteotomy may be the procedure of choice. If the acetabulum is small, one may have to do a shelf or a Chiari. One may have to augment it by these procedures. If the patient is skeletally mature and you have a concentric reduction, you could do a triple type of osteotomy or a Gans PAO. Where concentric reduction is not possible, well, Chiari or a shelf procedure will provide the answer. So open reduction with femoral and acetabular procedures, when do we do it? The hip is stable in neutral position with femur in abduction, internal rotation of greater than 20 degrees, and acetabular dysplasia is present, which is unlikely to completely remodel. So here's an example of this patient, a 7-year-old. Acetabular dysplasia is unlikely to remodel, and this requires a combined femoral and an acetabular procedure. Well, femoral shortening is very, very useful, and we resort to femoral shortening very often for a tight reduction, generally for a child whose age is more than 3 years old. But in some teratologic dislocations, we may do it even at a much earlier age. So another example of a child who had an open reduction with a femoral shortening. So this was a 2-year-old. She had an open reduction and femoral shortening. The hip seems to be well contained, but there is acetabular dysplasia. The pelvis should have been tackled in retrospect. It was not done. A year later, this is the presentation when she came for implant removal. The acetabular dysplasia is visible. However, before anything could be done, this patient disappeared from follow-up, and she presented at the age of 14 years complaining of pain in the hip joint. The right hip is painful. The acetabular dysplasia is present and something needs to be done. Well, the MRI shows the stresses which are at the lateral part of the acetabulum, at the most superior part of the acetabulum, and the labral problem as well as the degenerative changes which are happening there, the cyst formation. The CT scan shows the uncoverage which is present laterally much more, posteriorly also, as well as anteriorly. Well, this required a periacetabular osteotomy of the Gans variety. So after that, the containment is much better and her pain has disappeared, and this is a longer follow-up. So then there are concerns with older or with late presentations of DDH, because what could be the upper age, till when would you operate a unilateral hip? When would you operate a bilateral hip? There are no clear-cut answers here. Much would be based on surgical experience and the anatomic changes which have happened in the femoral head and acetabulum. If there are a lot of changes, this can lead to compromised surgical outcome or an ability to achieve concentric reduction. Then, of course, there are complications when you deal with older children and you try these sort of surgeries. There are bound to be complications. I'll discuss a few of these. And then long-term problems of satisfactory function and prognosis of the hip joint. So complications after surgery in late presenting DDH, well, avascular necrosis, there is conflicting opinion, but largely people believe that it has nothing to do with age, but possibly something to do with the extensive nature of the procedure which is required. Then residual dysplasia may be a feature if all components are not tackled with, or sometimes there is a propensity to dysplasia, and dysplasia develops despite an initial good reduction and stabilization. Subluxation or redislocation also can be issues, and subluxation has a very poor prognosis, and this needs to be tackled. Then you could have problems of femoroacetabular impingement and osteoarthritis. Well, this is from a paper by Lucchesi. I think very interesting survival graph which they have shown at the age of 45 with late presentations. This was children between 9 months and about 9 or 10 years of age, and they found that the long-term follow-up, well, the hips didn't last. They started having joint replacement from the age of 30 years after the surgery, sorry, and by the time they were 40, a large percent of them required a joint replacement. By the time they were 50, more than 50% of these patients required a joint replacement. So overall survival is a problem in these cases. So this is the problem of late presentation of DDH. Well, Lucchesi's group call it the lifelong disease. And yes, it is a lifelong disease requiring follow-up throughout life and requiring further treatment in life. So thank you very much for your attention. And I have tried to give you an overview of this sort of difficult problem of late DDH. Thank you.
Hello, everybody from Münster in Germany. Can you see me and the presentation? And do you hear me?
Yes, please go ahead.
Oh, great. Yeah. First, thank you very much to EPOS and POSI, especially to Sebastian Farr and Riyai Shangate, and of course, Hani Hiltunen for organizing this great and interesting webinar and for giving me the opportunity to talk to you about the most common and important difficulties of limb lengthening in children and adolescents. Unfortunately, I have to start with a statement that compared to other orthopedic interventions, limb lengthening is a very risky and complicated procedure. The actual surgery is one thing, but most problems occur in the subsequent period of gradual correction. Limb lengthening is ongoing surgery after suture. And to be honest, it's all about dealing with complications. That's why my boss always says, the colleague with the wrinkles on the face and the gray hair is the one for the colors distractions. There's a large variety of possible complications, so I can only address the most common, important, and severe ones in the next minutes. However, there's also good news. If you know and early identify the complications, you can handle them. I think many of you have heard about the traditional and widely used classification of so-called difficulties established by Paley for limb lengthening with external frames into problems, obstacles, and true complications. However, in my opinion, it is not well applicable to distraction osteogenesis using internal lengthening devices, and additionally tends to unjustifiably mitigate complications. Therefore, the colleagues from Texas have adapted the classification to the requirements of internal lengthening, for which our friends from Denmark recently found a good reproducibility agreement in both severity and origin of complications. Of course, even the indication for lengthening and patient selection is crucial for estimating and avoiding potential problems. Also, intra and perioperatively, subsequent difficulties can be avoided in general, and surgery-related complications such as neurovascular damage can already occur. However, most of those are not specific for limb lengthening surgery. Therefore, I would like to focus on the treatment-specific complications that may occur in the postoperative distraction and consolidation period, and that are either device-related or not. As you all know, limb lengthening can be performed either with external systems such as unilateral rails, classical Elisarov ring fixators, or modern software-controlled hexapods, or with internal devices such as fully implantable, motorized, or mechanically driven nails. Let's start with the most common problem, the pin site infection, which of course can only occur with external frames. It is safe to say that every patient treated with an external fixator will experience at least one pin problem during treatment. Two factors are crucial for avoiding pin infections: the appropriate insertion of the wires and half pins and the so-called pin site care. It is very important to use sharp drills to avoid excessive heat, to place the wires and pins without shear stress, and to put enough tension on the wires as well. And what about the pin site care? The procedures vary widely nationally and internationally and range from daily excessive cleaning and dressing to doing nothing at all to the pin sites. Thus, the literature is also quite controversial. This is a Cochrane review that concluded that the available studies are too weak to make clear recommendations on the necessity, frequency, and type of pin site care. In our daily practice, we have excellent experience with a very nihilistic approach. We only change heavily soiled dressings. We recommend only showering and avoidance of irritating agents. We leave the crusts as a natural barrier during fixator treatment and remove them at fixator removal. And in case of a pin site infection, only an antibiotic treatment is initiated. A superficial infection is simply treated by an oral antibiotic. The same is done for deep soft tissue infections. However, if necessary, the affected pin can be removed in the outpatient setting. Deep osseous infections are really exceptions, and like in this case, most affected pins are not properly placed right from the beginning. In those situations, the affected pin should be only removed or changed to another position if stabilization is needed. We looked at our pin problems during the last 19 years with approximately 50 frames per year and 12 pins per frame. That makes 11,400 pin sites, and we had to remove or change a total of only 8 pins, which means that we had I call it pin change or pin exchange rate of 0.7 per mil. Thus, almost all pin problems can be solved non-surgically without pin exchange. What about bad callus formation during distraction? To prevent so-called insufficient regenerates, distraction osteogenesis should be considered with caution in conditions that negatively affect bone healing, of course. The technique and the level of the osteotomy are very important, the latter especially at the tibia. A sufficiently long latency period of usually 7 days for the femur and 10 days for the tibia should be kept before starting the lengthening. And clinical and radiographic follow-ups should be scheduled every 2 weeks during distraction to allow adjustment of the distraction speed. For osteotomies, no large approach with preparation of the periosteum and use of retractors, but a so-called percutaneous osteoclasia with a small step incision should be chosen. A drill is used to set multiple cortical defects by tilting. A chisel or osteotome is then used to cut the cortical bridges between the holes, also by tilting in different directions, so that the bone is finally completely osteotomized. In insufficient regenerate, or if insufficient regenerate is identified, it is critical to stop distraction immediately and pause lengthening for up to 14 days, depending on the severity. In severe or missed cases, like in this patient, it might be necessary to relinquish achieved length and compress. The opposite problem of premature consolidation occurs more frequently in nail-controlled lengthening, because without an X-ray, it is more difficult to determine whether or not distraction has actually occurred. In addition to an appropriate latency period and sufficient distraction speed, it is crucial to accurately instruct patients in the handling of the fixator and especially of the ERCs, the external remote control for the nails, to avoid this. In early stages, one can try to increase the distraction speed or to perform a distraction of several millimeters at once. Otherwise, the only option is re-osteotomy, which must be performed either closed or open, with or without temporary loosening or removal of the hardware. Joint contractures are very common with lengthening, and the knee is particularly at risk. They occur regardless of the device used, but are much more frequent with external systems due to the soft tissue tethering through the pins. Many factors play a role. Often a vicious circle develops with protective posture due to pain and progressive muscle and joint contractures due to insufficient physiotherapy under treatment. And there is a risk of knee subluxation or dislocation, especially if the joint is already unstable in congenital deformities. To prevent this, transmuscular pin fixation should be avoided. Initial soft tissue release can be considered and joints can be stabilized from the outset. Regular clinical and radiographic controls are absolutely mandatory, just as sufficient pain management and intensive physiotherapy during distraction. External support with casts or orthosis can be considered as well. If there is a knee extension deficit of 15 degrees or more, distraction must be stopped immediately and physiotherapy must be intensified. If the problem is resolved within 7 days, distraction can be continued. Otherwise, compression should be done by at least 1 centimeter. If necessary, the distraction must be terminated permanently before the lengthening goal is reached. So that means severe extension deficits almost always lead to treatment failure, because it increases the risk of joint subluxation or even dislocation, especially, but not only in congenital conditions. During tibial distractions, the gastrocnemius pulls the femoral condyles posteriorly with respect to the tibial plateau without a rotatory component, which clinically causes a flexion deficit. Here you can see this kind of knee dislocation with a fixator and with a lengthening nail on the right side. The mechanism for femoral lengthening is somewhat more complex. The contracted hamstrings and the iliotibial band lead to a rotational subluxation of the knee that functionally cause an extension deficit. Here you can see the complex joint dislocation in a 3D CT scan. And here, in a case of fixator-controlled femoral distraction. We should be aware of the increased risk in congenital etiologies, but also other entities with previously stable joints can get the severe complication. So-called preparatory surgery can be performed before the lengthening procedure, for instance, improving hip containment, stabilizing the knee, and releasing soft tissue structures. The joints can be secured from the start, for example, by joint bridging frame mounting. And of course, identified joint contractures should be consequently treated. The Baltimore group always recommends a prior release of the iliotibial band in congenital deformities. We only do it secondarily when needed. However, we consequently create a so-called hypercontainment of the hip before we start femoral lengthening. And of course, we also reconstruct pre-existing knee subluxations before any distraction. If subluxation of the knee begins, the close reduction can still be attempted. We put the patient on a fracture table and the knee is shaken up and down and straightened during continuous longitudinal traction. Then a cast is applied for retention. In a completely dislocated knee, only surgery is a promising option. The knee can be mounted into the frame and can be gradually reduced. However, in many cases, extensive surgery with soft tissue and bony reconstruction is required. And unfortunately, once a joint has been dislocated, it usually suffers permanent damage, like in this case. Not only the knee, but also other joints, such as the hip, can be affected. Although a periacetabular osteotomy had been performed previously in this patient, the hip dislocated during nail-controlled femoral lengthening, ending up in a total hip replacement. Yeah, the methods to prevent delayed consolidation or even non-union in the consolidation period are the same as for callus insufficiency, and also the non-surgical treatment options, of course, are comparable to those in insufficient regenerate. Simple waiting can be successful, but not too long, usually no longer than 3 months. If no bone healing occurs, revision surgery must be considered. In partial defects, we usually perform intramedullary reaming for what we call internal bone grafting. For complete defects up to 4 centimeters, autologous bone grafting harvested from the iliac crest could be a solution. And in longer defects, the reached length cannot be kept in many cases, so we have to compress. And independent of the biological procedure, the bone should be stabilized using an intramedullary device. This is a case with femoral non-union after nail-controlled femoral lengthening, in which we could achieve complete consolidation only by intramedullary reaming and exchange nailing. In this case of tibial distraction using a hexapod system, the same procedure had been successful. This is an example of a 4 centimeter defect in which we were able to achieve complete consolidation by autologous bone grafting and exchange nailing. Fractures and secondary deformities can occur either at the callus site or due to inappropriate fixation of the devices. To prevent the former with fixators, it is important to correctly determine the time of frame removal. And to avoid the latter, it is crucial to choose screw sizes of maximum 1/3 of the bone diameter. Although the regenerate didn't look too bad with progressing consolidation, a refracture occurred, which we reduced and treated until consolidation with another external frame. That's why in femoral lengthening, we unexceptionally perform prophylactic intramedullary rodding for 3 months right after frame removal. Notice that the regenerate may break anyway, but of course without displacement. After fixator controlled tibial lengthening, thigh cast is applied for 6 weeks directly after frame removal. In this case of nail-controlled femoral lengthening, a fracture occurred at the distal locking bolts due to multiple attempts to hit the locking hole with a drill, and the fracture was stabilized with a trauma nail as well. It is not a good idea to place the most proximal screw in the femur cortically into the diaphysis. The forces on this screw are enormous and the fracture is not uncommon. A long screw in the femoral neck makes much more sense from a biomechanical point of view. To summarize, complications of limb lengthening are common and vary in severity. Pin site infections are not a big deal. Osseous complications concerning bone healing in both directions can be solved in most cases with or without surgery. Soft tissue complications, such as severe joint contractures or even subluxation or dislocation, frequently lead to permanent damage of the affected joints and should be avoided at all costs. However, experienced limb reconstruction surgeons are able to properly manage the complications. Thank you very much.
Able to see my screen?
Yes, it's all okay. Thank you.
Great. Good evening and greetings from Bangalore. I'll be speaking today on recurrent spastic hip dislocation, which is a problem frequently encountered by surgeons managing cerebral palsy. So the etiology of hip displacement directly relates to the child's ability to walk. Spasticity of the hip flexors and adductors, along with weakness of the hip abductors, are additional factors. More recently, attention has been drawn to primary abnormalities of proximal femoral geometry in children with cerebral palsy. So this is a graph showing the normal development of femoral neck anteversion in children from birth to skeletal maturity. We start at about 40 degrees of anteversion. Majority of the remodeling is complete by 5 years, and there is a much slower rate of remodeling up to 16 years of age. This study from Melbourne, published in 2008, shows a clear relationship between abnormal proximal femoral geometry and GMFCS level, which is the ability of the child to walk. So everyone is familiar with this graph where the GMFCS levels from 1 to 5 directly correlates with migration percentage and the risk of hip subluxation. This is new data from the 2008 study, which shows that femoral neck anteversion angle and neck shaft angle directly have correlation with GMFCS level as well. So increased neck shaft angle and anteversion of the proximal femur due to impaired mobility may represent the mechanism through which hips displace in cerebral palsy. And this is a significant and important difference or realization because we were always led to believe that it was spasticity that was the primary cause of hip displacement in cerebral palsy. So in terms of treatment options, they range from the non-operative methods such as the use of standing frames, postural management, abduction orthoses, and selective use of botulinum injection for the adductors, Moving on to soft tissue surgery, where typically the adductors and the psoas muscles are released. For more significant displacements, a varus derotational osteotomy of the femur can be performed, or this can be combined with a pelvic osteotomy, which is the so-called hip reconstruction surgery. You may notice that I have not included salvage surgeries in the treatment options because I believe, along with many others, that salvage surgery really should be playing no part at all in the management of children with spastic hip displacement. In terms of consensus, there really is no consensus in the literature on the exact indications for surgery, but most authors agree that a Reimer's migration percentage of between 35 and 45% would prompt them to perform some surgical intervention. Unfortunately, there are a few good studies with follow-up to skeletal maturity, and this is a lacuna that needs to be addressed sooner. An example of a 3-year-old male with bilateral GMFCS level 4 cerebral palsy. I've been following him up for some time, and he reached a Reimer's migration percentage of 50% at 3 years of age. In such cases, we always perform soft tissue release and should always be performed in both hips. You can see that the right hip looks relatively normal in this case, but adductor releases should always be performed bilaterally. And the reason for this is because of the effect on pelvic obliquity of a unilateral adductor release. It will cause contralateral hip subluxation, and this is well documented in the literature. So this is what we do, which is an extended adductor release along with a flexor release, which is done for both hips. The same boy at 12 months post-op showing good improvement in the migration percentage. The acetabular index has also improved. 2 years down the line, he is still holding, but you can see that the migration percentage is increasing slightly. But by 60 months of age, 5 years after the surgery, one can see that the hip has displaced significantly with an increase in the acetabular index, and he will require further surgical intervention. So looking at whether soft tissue releases work and using the need for bony reconstruction as the endpoint, Miller and colleagues showed that there was a 67% reduction in the need for bony reconstruction after an adductor and flexor release. Shore et al. With much longer follow-up showed that the success rate is much less than was previously thought. 2/3 of patients in their study required further surgical intervention. And the reason for this is that the GMFCS level 4 and 5 children do much worse when followed up over a longer period of time compared to the 2s and 3s. And this is called the paradox of soft tissue release, in that the children who need soft tissue release the most appear to benefit the least from it. But there are some real benefits from doing a soft tissue release at a younger age, primarily the ability to postpone the age at which bony reconstruction is performed. So this is a much older child, around 8 years of age, presented to us with bilateral established hip dislocation. And really the only treatment for this problem is to perform bilateral simultaneous hip reconstruction surgery, including femoral and pelvic osteotomies. So recurrence rates following reconstructive surgery is well documented. If a femoral osteotomy is done in isolation, one can expect 1/3 of children to require revision. When the surgery is performed in children older than the age of 6 years, younger than 6 years of age, and about 7% require revision if performed at an older age. When a pelvic osteotomy is added in the older child, the results are much better. But looking across studies, the overall failure rate after reconstructive surgery appears to be between 15 and 20%. But that also means that 8 out of 10 hips can be contained by combined femoral and pelvic osteotomy if it is performed after the age of 6 years. This study looked at the causes of failure. Children with a higher GMFCS level, the 4s and the 5s, are more prone to redisplacement after hip reconstruction. Hip reconstruction is not recommended in younger children, particularly under 6 years of age. Unilateral surgery, again, is not recommended. And if the acetabular index is high, more than 25 degrees, a varus osteotomy alone will not suffice. So how do we treat redisplacements after reconstruction? This is a 12-year-old boy who had undergone bony reconstruction by us several years previously, and he presented to us with increasing hip pain and inability to stand during physical therapy. So we believe in reconstructing these hips again, performing another varus osteotomy with appropriate amount of shortening. And in this case, we were able to achieve good containment coverage of the hip again with a shelf procedure. This is an example of a unilateral reconstruction that was performed in an outside center. Initially, the hip appeared to be contained, but by 5 years post-op, you can see that there has been redisplacement. And this boy underwent bilateral hip reconstruction with a left dega and shelf augmentation. And this is him 3.5 years later being able to stand for transfers with a good result and a pain-free hip. So revising a hip reconstruction surgery with further bony reconstruction is better than salvage. A newer option is proximal femoral growth modulation, and this aims to reduce the neck shaft angle through medial hemiepiphysiodesis. Proximal femoral growth modulation is recommended in the literature, and there is progressive subluxation in younger children under 10 years of age with at least 2 years of growth remaining. Most authors have noted a 10 to 15% improvement in the migration percentage after the surgery over a 2 to 3 year period. And this can be done either as a primary operation or as a post-op protective measure after hip reconstruction surgery. And this is an example from the literature showing improvement in neck shaft angle. The limitations of growth modulation include the need for screw exchange every 3 years or so. A pelvic osteotomy may need to be added if there is significant acetabular dysplasia. And this is a newer technique. The results at the moment are quite short-term, and we await further literature in this regard. Non-operative methods are quite important in isolation or as part of the post-op protocol following hip reconstruction surgery. A standing program reduced the severity of hip displacement in level 3 walkers, and fewer interventions were required when there was an appropriate postural management in the higher GMFCS categories. Hip abduction brace, if it is worn for 12 hours a day, improved Reimer's migration percentage by 10 to 12% over a period of time. So all of these non-operative measures should always be used as part of the post-op protocol after any form of surgery. So in terms of how we manage this problem of hip displacement, it's better to prevent by including all children with cerebral palsy in a hip surveillance program and start non-operative measures by about 18 months of age. Under 5 years, if there is progressive hip subluxation, perform a bilateral soft tissue release. And if and when the soft tissue release fails, we might do medial screw hemiepiphysiodesis. This should be between the ages of 6 and 10. And if hip reconstruction surgery is required, it should be delayed until after 8 years of age. If there is an isolated recurrence after previous surgery until skeletal maturity, we prefer to revise And the aim of all of this is essentially to prevent the need for salvage surgeries. And this can be called a ladder of containment, which every child with cerebral palsy may have to go through. So I would like to acknowledge the contribution of my teachers who have helped greatly in understanding the problem of spastic hip dislocation in children with cerebral palsy. Thank you.
Hello, my name is Frank Akadbet, talking to you from Adelaide, South Australia. So this talk is about the complications in common arthroscopic sports procedures. So for this purpose, I've done a review of the recent and relevant literature together with an input of my own experience in this field. As you know, arthroscopy is being increasingly used for good reasons. It bears several advantages over conventional surgery, namely shorter incisions, less bleeding and tissue damage. It allows full joint exploration and yes, a short hospital stay and early recovery. So for these reasons, fewer complications are expected. You're all familiar with this adage: first, do not harm; second, be careful; and third, cure. This is obviously applicable to medicine, which includes surgery and yes, also arthroscopy. So I have decided to include obviously complications, but also the revisions for failure. I will talk mostly about the knee, which is by far the most frequently scoped joint, more than 80% of the practice, with a special focus on ACL reconstruction, discoid, and also the deep venous thrombosis. And we're also going to talk about the hip and elbow. This first paper is about 1,000 procedures from a single institution over a 12-year period of time, and recorded an overall 14.7% complication rate, of which 2% were major, namely wound complication requiring operative revision, arthrofibrosis requiring manipulation, other unplanned return to OR, septic arthritis, and yes, one case of death. So the risk factors for major complications were a long operative time, a tourniquet time of 2 hours or more, and the surgeries, including 3 or more procedures, were also at risk. These meta-analyses focused on complications which are specific to the pediatric population, with a re-rupture rate of 8.7% and growth disturbances, axis deviation up to 1.5% of cases, the majority of them in valgus, and leg length discrepancy up to 2.8%, of which 27% required surgical correction. And in those cases which required surgical correction, a technical issue had been emphasized in all. So the conclusion were that growth disturbance can occur with any of the reconstruction techniques available, and a proper surgical technique is more important than the particular technique being used. Another paper on ACL reconstruction, this time is a chart review of 100 patients after transphysial ACL reconstruction, with a mean follow-up of 4 years, confirmed the re-rupture rate of 9%, and also reported on a quite substantial reoperation rate, 24%, and mostly for meniscal reason. Now we switch to the discoid meniscus, which is indeed nicely managed arthroscopically with good results. But this paper from Boston Children's focused on the long-term results, outcomes, with a minimal follow-up of 16 years, average 20 years. So the treatment was arthroscopic saucerization, so reshaping of the meniscus, together with the repair in 10 of those 25 patients. The revision rate was quite high, 44% at a mean 20 years. So revision for saucerization plus or minus repair. And the conclusion were that the best outcome is obtained for the individuals younger than 10 years or within 6 months after onset of symptoms. Now, concerning the venous thromboembolism after adolescent knee arthroscopy, the incidence is quite low, 0.25% over a 5-year period. So of those 7 cases in this paper, all of them were older than 15 years, and all of them had at least one of those listed risk factors. So the thromboprophylaxis is only indicated in the rare instances of multiple risk factors or established high-risk patients. We move to the hip joint, which is deeply located and a tight articulation. This review here focused on the complications of hip arthroscopy amongst 218 procedures over a period of 9 years. Indications for treatment were mostly labral tears, followed by impingement, POSI, and chondral flaps. So the overall complication rate was 2% at a minimum 12-year follow-up. So transient pudendal nerve palsy, 2 cases, instrument breakage, 1 case, and infection, 1 case. 10% revision hip arthroscopy within this time frame. And we have to bear in mind that this report, the activity of an experienced hip arthroscopist. Another paper from a very expert institution focused on femoral acetabular impingement in adolescents. No complications were reported, and 7 patients required a revision, up to 10% of the series at a minimum follow-up of 10 years. So the risk factors for revision arthroscopy was female gender with global laxity, and also the duration of symptoms. Again, this is a very experienced operator. Now we move to the elbow joint, which is smaller in size with a close proximity of the neurovascular structures. So this first paper reported about 26 procedures for arthrolysis, OCD, and also for posterior impingement. So the complication rate was 7.7% at a mean follow-up of 16 months. 1 major complication, triceps tendinopathy, and 1 minor complication, ossification. It was again a single senior operator. This other paper, very recent indeed, about 260 primary arthroscopies, reported an overall complication rate of 12.7% from 0 to 57%. The majority of them being minor, loose bodies followed by contractures and partial physeal bar of the distal humerus. Higher complications rate were reported in highly complex surgeries. My take-home message today is that complications and failures exist with arthroscopy, but as always, best is to prevent the complication, and you have to use all educational opportunities, workshops, simulators for arthroscopy, which are very, very good now, courses and meetings. You have to assess the operative time in a realistic manner and ask for support timely. The complex procedures have to be planned and staged when needed. And yes, you have to set reasonable objectives and expectations to the patient and family. Thank you very much for your attention.
So I
So
think
I think we really had a lovely battery of speakers, and All of them have been very exemplary, and thank you for sticking to time and keeping your subjects absolutely crisp. Dr. Far, should we go topic-wise or
Yes,
in the
please.
order that questions have come?
Yes, Dr. Mehta, please go ahead and start with the first topic.
Yes. So thank you, Dr. Nicholas, for the lovely talk that you have given. There are two questions for you from the audience. One is regarding the compartment syndrome in chronic compartment syndromes greater than 24 to 48 hours from injury. What do you see as the role of the fasciotomy being? Is it contraindicated or is it important in a disaster setting, especially when there is crush syndrome?
The big issue there is what happens once you open the compartments, and I think it really has to do with the setting you have, because you know that in this situation, if you open the compartment, you will produce severe, let's say, body and compromise that needs intensive care supervision, and the risk of infection would be much higher. So in other words, and to answer simply a complicated question, chronic compartment syndrome, unless there is a lack of pulse distally and you're concerned about amputation, should be performed only if you have the availability of a very good intensive care unit close to you for these children.
Right. And there's another question for you from Dr. Hakan himself. Lovely presentation. And is it indeed important to perform fasciotomy in every pediatric compartment syndrome due to crush injury? What are the absolute indications and contraindication in such injuries? And is there an uppermost time limit for fasciotomy in such injuries?
Well, I'm again very sorry for what happened in Turkey, and I have to say Hakan would be probably more appropriate to answer these questions. I know that 20 years ago, when more in 1999, when the first big earthquake devastated some part of Turkey, they published afterwards in Ankara a study on the advantages of doing late fasciotomy and let's say not the disadvantages, and they were actually encouraging in doing fasciotomy even if the child or the adult which they published the cases from had a crush injury. Obviously my experience is very low in this situation, and I know that this past year, a few months ago, when the disaster and this major earthquakes happened in the south of Turkey, a lot of children were transferred to both Ankara and Istanbul, and they did perform a significant amount of fasciotomy and amputation. I don't know. I don't know the true answer. Probably for me, the absolute indication for a fasciotomy in a child with crush syndrome would be an absence of distal pulse. That would be my simple answer to, again, a difficult and complex question, crush injury and compartment syndrome.
Thank you so much. Over to you, LK.
Yeah, thank you very much. So we go to the next speaker, Dr. Mukhobadaya, about the multi-unit forearm fracture. And we have to ask for short answers, please. Sure. Because we are short in time. So there is a question about conservatively treated mid-diaphyseal fractures, because you showed some of the children treated also with conservatively. And how long would you do the immobilization to avoid refracture of this kind, and how long you wait for the remodeling? So,
when you treat them conservatively, depending on the age, the casting would be usually around 6 weeks. Okay? Usually, if these fractures in children heal by then, except now the older child, I would not do a pure conservative treatment. So we would do either a titanium elastic nail, or in the adolescents, we might even go to reduction. In the younger child, where we are treating just with a cast, it would be about.
Mm-hmm. And also a question about correction osteotomy, because you said that you showed several cases with a correction osteotomy putting plates on not very well remodeled fractures. So at what time you would do the correction osteotomies?
So for a short answer, I think if you feel that the malunion is not within acceptable limits, then there's no reason to wait. Okay? If you think it is within the acceptable limits, then you would wait for it to remodel. And if it doesn't, then you would go and do an osteotomy. Again, in the younger child, you would expect more remodeling. In the older child, you would expect less. And adolescents, we treat as, I would treat them anytime they come, basically.
Mm-hmm. And the last question is about the waiting time, because you say a younger child, older child. So usually in adults we say, well, pseudoarthrosis is at 6 months. This is not you don't have a union. But in the, for example, I give you an example like a 10-year-old which is at 6 months not healed. What would you do with a mid-diaphyseal fracture?
So if in a 10-year at 6 months, treated conservatively or with the nail?
No, no, with nails, not with nails.
Okay, so if it is a reasonable position, I would wait maybe up to 9 months. But if it's a maluniting fracture, I don't see any reason to wait for that. So I would go ahead and do it before it unites, rather than wait for it to unite and then do an osteotomy. So you can correct it before it unites if the position is not acceptable.
Okay, so thank you very much. So as I go to the question for the next speaker, Professor Johari. So there was a question again about the upper age of the open reduction. When would you stop the open reduction? You showed some cases, and one person of the audience asked about the upper age of a reconstruction, please.
Yes, LK. Well, it would vary from case to case. You know, how good is the femoral head? How good is the acetabulum? Whether there are intra-acetabular changes, for example, bicompartmentalization or a ridge formation and all that, you know, we would have to assess that patient. But generally, in practical parlance, a unilateral dislocation, maybe about 15 years of age would be my upper limit. For bilateral, I'm much more careful, you know, because the results for bilateral not always symmetrical or good, you know. So again, case by case, I showed you an example of a 13-year-old. Well, maybe I selected that, you know, but I would be very cautious about bilateral DDHs.
Okay, thank you. And I have also a second question. It's about the Ganz osteotomy, and which may lead to avascular necrosis of the femoral head. And what would be your management if it appears? And it's written if they ask if there's a difference of treatment according to age.
Well, I'm not really an expert or authority on the Ganz osteotomy, but from the literature, I know that the incidence of avascular necrosis is pretty low after a Ganz osteotomy. In fact, for the femoral head, it's been quoted as 0.2%, you know. And for the acetabular fragment can become avascular, but that's also pretty low, 0.6%, you know. So if at all this sort of problem happens, you know, it's a calamity. One would again have to weigh the clinical situation. I mean, the treatment for any avascular necrosis is containing that femoral head within the acetabulum, you know. And if that is contained, I would expect things to reshape in some way, at least, you know, to have a fair functional result, you know. So that's my feeling, you know. One would have to follow up this case and see what happens, you know. In the worst case scenario, of course, you can go for a total joint replacement, you know, in appropriate age.
Yeah, thank you very much. I have to give again to Dr. Mehta, please, for the next speaker, the questions.
Yeah, thank you, LK. Well, the next question is for Dr. Bjorn Vogt. Excellent talk, Dr. Vogt. The audience wants to know if hip dislocation occurs when lengthening the femur, especially in a congenital femoral shortening, and if it does not relocate even after the shortening. You know, when you have a dislocation, you try to shorten and handle that.
Yes.
Then what could be the possible answer? Would open reduction be the only solution?
Yes, very good question. Thank you very much. Yes, indeed, this is unfortunately necessary in most cases, but fortunately, hip dislocations are not common. I've only had to observe them in congenital femoral deficiency so far, although we had created hypercontainment, as I showed you, hypercontainment of the hip before we started the lengthening process. In most cases, the ipsilateral knee was either stiff or mounted into the frame. So that means that all decentering forces act on the hip, and that was a problem. Yeah, in one case we were successful. I think it was an 8-year-old boy, just by complete shortening and application of a speaker cast. So reduction and application of a speaker cast for I think 12 weeks. But otherwise, we have had to perform an open reduction in combination with a pelvic osteotomy. Yeah,
and as a follow-up question from me on the same topic, how do you deal with counseling the parents when such a situation occurs?
Yes, of course. This is a very good issue or important issue. You mean before the surgical intervention or after it happened?
No, when this does happen, if a dislocation of the hip does happen in the process of lengthening.
We tell them that it's a severe complication, that the hip can suffer a permanent damage, and that we do our best to solve the problem. But it's absolutely right that this is a very, very severe complication, and in many cases the hip, so in our cases I think we had about 5 or 6 in the last 15 years with hip dislocations after lengthening, and we could manage to reduce all those dislocations. But the risk of osteoarthritis and permanent harm to the joint is, of course, this is a reality. Yeah.
Thank you so much for addressing that tough issue. I hand over to you, LK, again.
Yeah, thank you very much. So now for Dr. Sampath, thank you very much for your excellent talk. Challenging topic, and most of the questions are about your remark that you don't do salvage procedures anymore. So I totally agree with you, but there were questions. So what would you do dislocated? So the question was a GMSS4 dislocated neglected with a eroded head. So would you still consider reconstruction, or you would do a salvage procedure? So the people are questioning about this salvage procedure.
So salvage procedures have a really bad track record with pain, and in fact, most patients appear to be worse off after the salvage procedure than they were before. And my own experience a few years ago has been similar. So we have just completely abandoned doing any salvage surgery, and I have done as much as the same bony and femoral and acetabular reconstruction 3 times in the same patient, and in the end, over a period of time, we do achieve adequate containment. And the saving grace in this is that the GMFCS levels where this type of redislocation happens repeatedly, it's in the 4s and 5s who don't have that much of a functional demand. So if you can keep the hip reasonably within the acetabular, even if it's not perfect, I think for most functional activities, it's satisfactory. But I think as a group of orthopedic surgeons, we should just move away from even thinking about salvage surgery. That's why I did not even put it in the slide. I think salvage surgeries should just be historical.
Yeah,
because thank you very much.
Yeah, thank you very much. I agree. So please, Dr. Mehta, for the last speaker.
Yes. So a question from me for Dr. Frank. How often do you see a compartment syndrome as a complication of pediatric arthroscopy? And if so, more in the lower limb or in the upper limb?
Well, thank you. This is quite rare and fortunately enough, but it does happen, especially with the long-lasting cases with a long tourniquet time, and this is mostly at the lower limb, not to say exclusively. So what I've heard of from the literature and also from my experience.
And Dr. Lutz, I think there's one more question for you. Sometimes a foot drop can happen as a consequence of compartment syndrome. Do you think that this is caused by muscle or nerve dysfunction? And do you think that peroneal nerve release is indicated in this case?
I think you can probably assess it and see if the nerve has been injured. We've had lately a girl with a proximal fibula injury, which affected actually the nerve and not the muscle, and had the foot drop. So my concern would be first to do the difference between the two by assessing the nerve and maybe doing an EMG and then proceeding with the treatment accordingly, depending on the origin of the injury, if it's nerve or muscle.
Sujita, can I just comment on that? Because we've seen quite a few of these cases where only the anterior compartment is involved. So the entire anterior compartment and part of the lateral compartment is dead, while the medial and posterior compartments remain alive. So these present with a foot drop. So if you get one of these patients presenting late with a foot drop, and you open them up, you'll find that the anterior compartment muscles are totally gone, rather than the peroneal nerve involved. So this is something we've seen obviously more in the adult population than in the children, but this is something that one has to be aware of, that the compartment syndrome is not always a all or none phenomenon. It can involve only the anterior and lateral compartments more than the posterior compartments.
Right. Absolutely.
Yeah. I think time is flying, so I go back to Sebastian.
We are flying. I thank all the speakers, the faculty, and the co-moderators, and also the audience for their contribution, for their great questions. And I hope you did learn a lot as much as I did. I'm happy for this great program. I would like to give the words to our president for the outro.
Thank you once again, Dr. Hakan, Dr. Far, and thanks to all the faculties, Indian faculties, Dr. Zuhri, Dr. Jayant, and Dr. John, and our moderator, Rujita. Our Alaric, our president POSI is a busy man from Mumbai. He's always tend to have more collaboration with international societies. So I think in future we will be able to conduct more webinars with more collaborations. Over to President Alaric and Hakan. Alaric, you want to say something?
Yeah, you can be sure that EPOS and POSI leadership are willing to improve this collaboration. You can be sure. And thank you.
Okay. Thank you. Thank you so much.
Thank you.
Thank you all. Bye.
Bye-bye.